morning to everyone. My name is Paolo De Coppi, and I'm one of the consultants at Reconstruction Street Hospital. It's actually very emotional and quite difficult to just come after Mac's parents, and it's remarkable, and I always get enthusiasmed by what parents and what personal experience can do, that us as doctor can only be there supporting all of you, and it's certainly our duty to do so. And so thank you very much for sharing what you have done, and thanks Greg to pursue this internationally, and it's quite remarkable. So it's a pleasure to be here, and let me just get started. It doesn't seem to recognize it for some reason. Yeah. Usually works, huh? Yeah, perfect. So it seems to work, which is great. And so sorry I'm being a bit late, but I found myself on the other Hilton, and I realized I was in the wrong place when they start with the confetti, because it was a wedding anniversary. So I thought that was a bit strange, but I found my way. Thanks to Ati, I called her, and she put me in the right direction. So it's a pleasure to just introduce the medical session with a bit of medical knowledge. I know that you are all very knowledgeable by now about the Anorectal Malformation, so I will try to make this interactive. So please interrupt me if you have any question, comment, and so on. So it would be easier to explain, and I will try to be on time. So you know the definition is an embryological problem. So something goes wrong during development, and development is quite complex, and so sometimes we as professionals are surprised that more things don't get wrong during development, because it's such a complex phenomenon and such a complex thing that needs to happen to make it in the right way, that you get surprised that everything goes smoothly. So you have to think that at the beginning is like a small plate, the embryo, and then it starts going around itself and forms different tubes. They get connected, and then form the different part of our body. Many things in our body are formed initially as tubes. The heart, the gut, of course, and then all the rest. And these tubes get connected. Even the kidneys start as a little tubes. And so these two tubes needs to be connected. That is the hindgut. So the hindgut is the lower part of our intestine. So we have a foregut that forms the upper part, and then we have the hindgut is called. And this hindgut needs to get connected with the cloaca, which is the part that forms all the urogenital part plus the rectum and the anus. So on the anterior you have something called the allantois, will hand up forming all the bladder and the tubes that goes up to the kidney. And the posterior part you have this hindgut. They both get connected to the cloaca. So we all developed as a cloacal malformation, if you wish, in the sense that we are all developed, that we have a common sac where all these tubes get connected. And then this septum that is here starts separating the two, so you have a proper urothelial or urogenital part and the rectum divided. And so that's what happened over the time. So these cloaca get divided more and more. So you have anterior, you will have the urethra and the rest, and here you will have the rectum and the anus. And these start connecting, and you can immediately understand firstly, how things can get very complex and you can get problem on the urogenital and the rectum. But also, importantly, is the fact that if you have a problem on the posterior part, you may have a problem also on the anterior part. And I know colleagues of mine will discuss about this later on. And so you all get connected, and if everything goes well, you have a perineal body that will have the two things divided, but these things, as we said, can stay together. So the anorectal malformation get formed because there's a problem there. There's a problem on the formation of the septum and the separation of the organs that needs to be formed in that pipe. And therefore, it's very easy to classify those malformations because things can get wrong because the septum don't grow at all, grow very little, and so you have a proper cloaca, which is the one of the most serious of those problems. But actually, everything gets separated until the real end, and so you have maybe a fistula that is appearing in the perineum and is separated from the rest, but hasn't developed completely. Or you have this part that still get connected, so you have a fistula between the rectal part and the urethra, for example. And so by doing that, you can see that both in males and females, of course, it's more rare in males, but you can have a perineal fistula, so that the rectum get down to the bottom and they are separated from the urethra part. Or more frequently in males, you can have a rectourethral fistula, so it means that the rectum is ending up in the urethra, on the back of the urethra. That's the most one of the most common in males. And if that, instead of ending up on the urethra, ends up on the bladder, then you have a fistula with the bladder, so a rectovesical fistula. And you understand, by understanding the images of the embryology, how these things happen. So is this septum going in, and if it doesn't go until the end, you have different degree of fusion together. And of course, if the rectum end up, instead of being on the urethra, is on the bladder, then it's more severe in terms that hasn't divided as much, and so therefore they are connected together. And very similar in females, that of course fistulas are some area, either in the perineum or in the vestibula are the most frequent one, but you can miss those fistula, or you can have altogether a cloaca, as we discussed. And so based on that, and I'm sure during the day there will be more discussion about this, you can do or not have a colostomy, but this is very controversial. So if you had a child with a fistula, but nevertheless had a colostomy, is not wrong. It's different way of approaching the same problem. But as we discussed, and again, that's why I wanted to show you a bit of embryology, because it's easier then to go on the various defects, is that in male, you can have the fistula coming down, which is rare, or most frequently you have the rectum, as this, if you imagine here that the embryo is the septum that should separate the two, it doesn't work so much, and therefore the rectum goes together in the urethra. And when this is more severe, and you see you have less of a septum, so you see here the septum, and you see here you have less of a septum when these rectum finish in the prostate in a male, of course, in the urethra, or even on the bladder, and this septum is up here. So you see how embryologically you can understand why the different defects happen. And of course in male, the most frequent situation is that the rectum end up somewhere in the urethra. Of course this doesn't happen in female because you have another structure there in the middle that is the vagina that get formed. And so in female, situation is a bit different, but again, you have a situation in which you can think about this as a septum between the vagina and the rectum can finish as a fistula, as a vestibular fistula. So this is in the perineum, so it means outside the vestibula, or it can end up in the vestibula, or can end up as a common channel with the vagina, with urethra, then forming the cloaca. And again, in female, that's the most frequent defect. So, talk about the anatomy, you understand that we don't know very much why this septum doesn't migrate and doesn't separate, but there are certainly associated abnormalities that being most frequent, and you understand again from the embryology, on the genitourinary system, because the two things form together, so it's likely that there's a problem on one side, there could be a problem on the other side as well. And those always need to be investigated. But because we don't know why this septum doesn't migrate, we know that this can be associated to other abnormalities. And cardiac abnormalities, let's say, are associated very largely with any of these congenital structure abnormalities. And it's because if there's something wrong on the development, the cardiac, which is one of the first happening and one of the most complex, is likely that it can be associated. So the cardiac abnormalities are associated to many of the abnormalities that we treat. The anorectal is one, but also the esophageal atresia, for example, is another one. Diaphragmatic hernia also. So all these structure abnormalities may have also cardiac abnormalities because of the complexity of the cardiac and the fact that the cardiac is very early on, it's one of the, it's the first organ really that appear. And there are also skeletal abnormalities, spinal cord, and others. And this drive all the investigation that we need to do, and your children had, either as newborns or later on in age. And of course there are the incidence of those abnormalities change with the type of abnormalities that you have in the first instance in the anorectal. And this is because it's quite clear from the embryology that if the two do not develop separately, then you have a problem on one side and also on the other side. The classical example is the cloaca. So it's the fact that you don't have a separation between the two systems. And because of the complexity of the malformation, you have associated other anomalies that makes it on a syndrome. Now, most of the time, there will not be a syndrome, so there will not be so many association to other abnormalities to make a syndrome, but some of the syndrome that are written here are associated, and some of your children may have those, so you may very well known this, and this will be important mainly for the outcome from the anorectal malformation. So, just, yes? Yeah, they are ranked in an order of sort of a frequency, in the sense that the Bacterial is one of these association that can have other anomalies. The list is very long, and some are very, very rare, so I haven't even listed there because it doesn't make much sense. But the concept is that this is one of these malformations that can be associated to others, problems and other anomalies. So it's very important to exclude those, to make sure that first, as the parents, we can tell what is going to be the prognosis, what are going to be the problem that they need to face, and second, to make sure that we offer all the support that we can to the child, starting from earlier on, to make sure that we don't miss things. But many of children just have an anorectal problem with maybe some association with the genitourinary, but they don't have those syndromes. So the treatment now, it's very difficult, and I don't want anybody to feel that, oh, I probably didn't have the right treatment or the wrong treatment. There are points of discussion among professionals that we don't know what is the best to do. One of the classical examples is which type of colostomy to do, and I will tell you a bit about that. Or if doing a colostomy or not, if there's the fistula in the perineum. These are controversies, and in medicine we have many of those. So I'm happy to answer any question on this. But essentially, at the beginning, you have all been told that the surgeon needs to decompress the child, otherwise it would perforate. I'm sure that's a common thing that many of you have heard from the surgeon. So when the baby is born, of course there's air, meconium, and so on that we need to decompress. Either we can decompress from the bottom by doing an operation straight away in the anus, or we have to do a stoma. There's no other way, in the sense that if we leave it there without decompressing, then it will lead to severe complications. So that's the first point. And then it can be exactly that we don't do a stoma, we do the reconstruction of the anus, or we do a stoma and then we delay the reconstruction of the anus. Again, the 3 months is a sort of an average time, but it can be much later. For example, if children have problem with the cardiac, we delay this, and children can stay with the stoma for a very long time without causing any harm into that. So we have to take this in association with the old child. I put a question mark on the anal dilatation. This is a very controversial thing because many people think that is not needed, and certainly we at GOSH, we don't do it as a routine. Other centers do it as a routine and believe that this is important. And then, of course, after the reconstruction, the colostomy can be closed. So when we talk about which type of colostomy, the one that is more commonly used is is with the stoma separating the proximal bowel, where the poo will come, to the distal bowel that will be used for the reconstruction. This being popularized by Alberto Peña, and is to make sure that no content from the proximal bowel goes into the distal bowel for many things, because the distal bowel may be connected with the urogenital system, and so therefore you can cause infection, because it's believed also if poo goes here and dilate the bowel, it may be more dilated, more difficult to reconstruct. So all these situations. So the image that will be common for many of you to have seen on your baby was a proper stoma and a mucous fistula. This again is a concept that the majority of surgeons will take on and will use to avoid problem on the distal bowel. But there's an alternative, and the published data show that actually, in reality, there's no much of a difference between this type of stoma or a loop colostomy. So it's called loop in the sense that you have in the same hole, you have the proximal and the distal bowel. So some other parents here may be more familiar with this type of stoma. So we do this type of stoma routinely for many years now, and we haven't seen really the problem of the infection or the problem of the dilated bowel, because we believe that actually is a matter of pressure. I mean, doing surgery is like being a plumber, and it's a matter of pressure. The poo will come out in the bag. I mean, was he to have a very smart poo to decide that he will have what to go here instead of coming out in the bag. So this we never found a problem with that. But again, it's a matter of controversy, as many things in medicine. The advantage of this is that mainly makes the operation much easier, because you don't have to do a proper laparotomy to do a stoma, but you bring it out through the same hole where the stoma will be placed. And the closure of the stoma is also much simpler, because the two holes are close to each other, so you can just join them together. The other colostomy, of course, is much more cumbersome in the sense that you have to do a larger operation and so on. However, there's another stoma that you may have come across, that is that If you have a more complex anomaly where the rectum end up in the bladder or there's a cloaca or so on, then the stoma needs to be much more proximal, usually on the transverse, to allow to have enough bowel distal to make the reconstruction possible. So to bring the colon or the rectum down to the anus without having the problem that by pulling you don't have enough bowel. So that's another type of stoma that you may have come across. And then there's the reconstruction. I mean, the reconstruction, there's various type of reconstruction, but essentially the one that has been popularized by Alberto Peña and most of surgeons will use will be a posterior approach. What is the advantage? The advantage is that you follow the anatomy. So you open the skin and you follow the muscle that are coming up to the skin to place the bowel. So the fact is that you follow the anatomy until you find the bowel that may be also very far away from the skin, and then you try to position the bowel back where it should be on the muscles there. And this, by doing that, of course, you may have to separate a fistula, for example. So while you're approaching the bowel, you may find a fistula with the urethra that you know of this before because of the contrast and so on, and you bring this forward. And in the same matter, it's on the female reconstruction again. It's from the posterior approach. Most of the time, as I said before, you have a fistula there, and you move the fistula in the right position. By doing so, you don't have only to move it, but you have to mobilize also the rectum to make sure that it's in the right position, as you can see here, done. So then you close the tissue where the fistula was positioned, and you place the rectum in the right position there. There are now surgeons that would prefer to do this laparoscopically. So if you have a high connection, you have to imagine that going from here to here, firstly, it may be very, very difficult because there's no, here you have bone, so there's no enough space to mobilize and to see. Second, you can create some damage because maybe you go into the urethra instead of going into the rectum, so you need to be very careful. So what we do when we have this type of situation, we go with the laparoscope and we close this fistula, and then we turn around and go from the back. Some other surgeon would prefer to go from here and then continue from here. So I show you some images from inside, but essentially what you see is the bladder and the fistula ending up in the neck of the bladder. And essentially what you do there, you divide this fistula, and you can do it with clips or ties. And then once you divide it, you see the fistula, and then, you know, it's not very clear here, but you try to go down in this space and to place the rectum in the right space. So I draw something which is a bit better than that picture, but essentially you have to do, here is the prostate, these are the muscle that you, as you've seen before, you clearly see very well, and you go down in the position where the rectum is. And you can help yourself by going up from the bottom and see where the rectum needs to be positioned, and you pull it through with some instrument. We don't do this at Great on the Street because we do the approach of dissecting from above, but then we like to go from below by looking at all muscles to make sure we are in the right position. But the other centers will do that. The last thing is what to do after the operation. So we have to wait about 6 to 8 weeks to close the stoma, and in the meantime, what to do. So some other centers, I mean the majority of the center actually, would give the parents those or similar type of instrument to dilate the neo-anus or the neo-rectum. We don't do it, and this was started a long time ago before randomized controlled trial and all this type of research. The surgeons at Great Ormond Street Hospital saw that there was no benefit of that, and so we are continuing not to do that. And we've done some study comparing our results to other centers that will do routine dilatation, and actually there's no differences on that. So the plan now, we discussed this also within BAPS, that is our British Association of Pediatric Surgeons. We want to do a randomized controlled trial to really have some patient that will do the dilatation, some patient that will not do it. That's the only way to establish in medicine if a treatment is needed or not. Because we believe it's quite stressful to parents to have to do this to their children, and if there's no real benefit, we think that it should be stopped. However, in order to stop, we need to make sure that we are not causing more trouble to patients. And so Daniel Malseri, one of our consultant colleagues, is trying to do this type of study. So some of you may be contacted for that, because it would be nice to have your opinion also on what is best for a patient. So just a brief summary. It's important to know the anatomy. So that's why I started from the embryology, because I think by doing that you understand why the two things are connected, for example, between the urogenital and the rectum. There are different ways to do things. I mean, some would prefer to do a colostomy in one way or another, as I explained, and then the repair. We usually suggest that the classic repair, so stoma repair, closure of stoma, is the safest, because anything can go wrong if you don't do it in the right way just in one go, because you can get infection, for example, and then it's a big problem for children in the long term. But that's possible as well. In the neonate, in the real neonate, to do a big operation is sometimes difficult because the structure is not so clear. If you do a little PSARP or mini PSARP, that's okay, but to do a big reconstruction is difficult, so waiting a bit is important. And as you all know, the long-term follow-up is really the crucial matter in this problem. So thank you. I would like to thank also Stefano Giuliani, one of my colleagues. Yeah, so that's what we've been advocating for a long time. We've done studies demonstrated that actually there's no difference on that. But the North American literature is very strong and is, I mean, nobody has the experience of dotopenia. So dotopenia is very adamant on the detached stoma. But he recognized as well that there's never been a proper study looking at the difference between loop colostomy and detached colostomy. The real difficulties there is to run the trial. As I explained, for the dilatation would be not so simple, but it would be easier. For the colostomy type of colostomy, I'm sure if you put 100 pediatric surgeons in this room, you will have a completely different answers on that. And the difficulties is that until we reach an agreement to do this type of study of trial, we will not have a final answer. What I can bring is the experience of 35 years of doing loop colostomy at least at Great Ormond Street Hospital with no major issue on that. And we're certainly not going back to the mucous fistula. However, waiting on both of colostomy is not a major issue. I know about the problem with the mucous fistula, though, if you leave it there for a very long time. Yeah.
Thank you.
No problem. Yep. Sure.
Are there any, what are you most excited about in terms of the techniques in surgery
around this condition? If you look forward in terms of the next 5 to 10 years, are there any sort of...
Yeah, I mean, there are some of the technique coming up in mainly in simulation and reconstruction that could drive surgeon to place the rectum in the right place on the muscle, because at the moment we are guided by anatomy, by what is our experience, by an instrument that excites the muscle, and we can test that. It's called penia stimulator, and we can decide where to put a place on this. There's now mainly coming from adult surgery, from colorectal surgeon. There are some of reconstruction that can also through MRI can take the information of the MRI and place it on a robot, for example. So there in the Da Vinci is a robotic surgery that they use for adult surgeon, and they use that mainly to look at, for example, nerves that are present there, and that they can guide them to preserve those nerves. And this is also happening for the prostate surgery, for example. And these are two areas where it's quite exciting. So this is a simulation, reconstruction, and robotic surgery working together with artificial intelligence to try to drive safer surgery. So this is very exciting. The problem is to scale it down to neonates. It will take some time. I'm sure there will be more question answer after the next speakers.
Yeah, we're going to have to. There is a question and answer session at the end. So can I ask you all, if they are specific, Paolo, could you write them down and save them, because we're just a bit conscious of time, and we want you to hear everything else that these amazing people have got to say as well. All right.